hepatitis C elimination in the country. He is a former hospital director of Diriyah Hospital. Without further ado, Dr. Abdullah, you have 15 minutes.
Thank you for the kind introduction. And just to add on hepatitis now and its value in terms of the interests of the hepatologist groups. When I was invited to do this presentation, it was almost in an apologetic way. We have something we wanted to introduce or to present, and it is hepatitis C, almost again in an apologetic way, because things have moved significantly. And it's one of the thoughts that I had when I was preparing this presentation is actually young hepatologists now have never seen the days of early direct antivirals where we had very complex tables, multiple variables, let alone interferon therapies. So what I did in preparing for this talk, I took it literally, the best of the liver meeting. So I went through all the abstracts, more than 4,000, and I picked the hepatitis C related abstracts, around 200. So you can see again 5% almost only related to hepatitis C, and I just picked them up quickly. And what I'm going to do is rapid fire abstract and a message, and I'll go through those topics that's either reinforced something that I already knew before or something that I think would be of interest. So starting with the transplant with hepatitis C, what's new? This is not new, but it's an abstract that was presented. It presents a unique Toronto protocol for dealing with patients who have hepatitis C. So basically, 1 day prior to transplant, patients would receive glycaprevir, pipentosvir, and ezetimibe, and then the patient will go for transplant, and then continue with only 7 days of the treatment. And this is what we call the Toronto protocol. And they had more than 100 patients, all of them non-transplant, non-organ for liver transplant. Kidney was around 50%, lung, heart, and so forth. And the SVR results were 100%. Would this change my practice? I don't think so, although the results are very impressive, but it's something to keep in mind. This is very short, ultra short treatment strategy that resulted in such good response. The next abstract, 3422, this is again whether we need or we should offer the organ that are positive with hepatitis C, a big cohort, more than 15,000. And it was, again, looking at predictive models of the chances of mortality while on transplant lists versus for those who are accepted the organ that is positive versus those who didn't accept, and whether the transplants would go ahead or no. So as you can see in the up, there are two ways of two methodologies of predictive modeling. Both of them show that the patients who agreed to go with the organ had better outcomes in terms of mortality and in terms of actually getting the transplant. So with this change my approach, again, we don't have a big pool of hepatitis C, unlike maybe the West, for those who are donating cadaveric organs, but it's something definitely to keep in mind. Another topic, post-SVR outcomes and risk stratifications. So this is regarding treating of decompensated cirrhosis. This is again something to confirm or reaffirm what we already knew, that patients who are decompensated, even if they don't go for liver transplants, the outcomes would be better. This was on 200 patients from Japan, and the follow-up was relatively long, around 4 years. And the liver transplant-free survival was better on those who achieved SVR. The further decompensation events were less. However, the de novo HCC did not reach statistical significance between the two groups. So would I change my approach? Again, I'm already treating patients. This is just affirm my approach for such group of patients. Another related topic about the HCC incidence after SVR, and this is very practical for me, for my practice. I've seen this in my practice, and this abstract confirmed it. Again, looking at a large group of patients, 3,000 plus, and the follow-up of 7 years, up to 7 years. And what they observed is that we all know that there's a risk of HCC, but it seemed like the risk of HCC or the incidence of HCC a bit goes down, but then there's another peak after 4 to 5 years. And this is something, again, I've been noticing in my practice, patients who are developing HCC years after we thought that things have settled down. And that peak really caught my attention because it goes with my day-to-day practice. And the message here is we don't lower our guard in terms of HCC surveillance. Again, after SVR, what would happen is someone who has decompensated cirrhosis. Here, the main focus on ascites. So around 1/3 of the patients would have resolved ascites after the treatment. And who are those who will have the resolution of the ascites are those who have less decompensation. So ascites grade 1, they will have more. Those who didn't have variceal bleeding previously, they will have more resolution, and those who had no hepatic encephalopathy will have more. So it's just maybe a practical question that we see in our clinic when a patient who's not for liver transplant asks us about what will happen. We can tell them that things can improve, but marginally. This is, for me, this is one of the most important abstract, at least from my perspective. So first, they look at, it's a systemic review of a very large group of patients, and from different studies, like 81 studies. And they look at, among patients who have HCC and hepatitis C, how many of them were treated. And as you can see across the board, globally, the number of patients who were treated is not high. There is always the concern that if we treat someone who has active HCC, and we don't control the HCC might becomes more aggressive. And I think that's always in our mind. For me, that's something that I even tell my fellows, that maybe we need to control HCC before we go and achieve SVR. And again, it's consistent all over the world that that's what's happening. However, the findings here are quite interesting. We know that overall the outcomes would be better if you cure hepatitis C. But even in patients who have active HCC, outcomes were better in terms of mortality. As you can see on the last column, patients who have active HCC in terms of the mortality risk was significantly lower in those who achieved SVR versus those who didn't achieve SVR. So with this change my practice, perhaps this is one of the few abstracts that have changed my approach. I would be more inclined now to just go ahead and treat hepatitis C virus, even if the HCC is in its early stages. Of course, if I have something scheduled very soon to address it, whether it's local regional or otherwise, I might still wait. But my guard in term or my threshold for treatment now for such patient has been lowered based on the data here. So again, this is basically what I've mentioned. The treatment significantly reduced the recurrence, and the DAAs cut the mortality overall by 75%. One of the things that we still struggle with is the elimination. As the chairman mentioned, that Saudi Arabia is part of the countries that are on track for elimination. But again, this is a WHO roadmap, and they didn't include the data from the kingdom. This is just to highlight there's only 3 countries that are in the gold area. Again, our colleagues in Egypt are always there, but now Norway and Rwanda is also in the gold like assessment for elimination of hepatitis C compared with other countries. I think this is the approach now to go and further eliminate hepatitis C. Sorry. And it's, again, by targeting microelimination programs. This is a very good approach that was done in Taiwan. They looked at diabetic clinic for patients who have retinopathy. And the cohort was large, like 46,000 individuals. They screened 80% of them. And the incidence of hepatitis B, the prevalence of hepatitis B was more than double the national prevalence of HCV in Taiwan. So it was 8%. And most of them had RNA done, and more than 50% had positive RNA, and they were treated, 94% of them. As expected, everything improved. But again, I think this highlights that probably this is the approach that we need to take microelimination in multiple areas or multiple patient cohorts. So some caveats and treatments, again, nothing major here, but it seems like the sofosbuvir, velpatasvir can be used for 8 weeks. This is prospective, open label, randomized trial, non-inferiority between 12 and 8 weeks. And the message here, whether you go by intention to treat or per protocol, the 8 weeks is equivalent to 12 weeks. So this is, again, might change the practice. So we have now 2 regimens, both of them are 8 weeks. Of course, this is a non-cirrhotic group of patients. This is more of a modeling, just to balance the scale. Looking at patients who are acute hepatitis C, this is a bit lagging because now the old approach of waiting for chronicity, to prove chronicity after 6 months has been eliminated. We treat now once the PCR is positive. So here they did some modeling that if we treat immediately, it's better than the 6 months, which is, again, something that has been already well established, and that there is some cost saving in doing that approach. Pregnancy, again, multiple abstract, but I picked up the 2 of them that I think had some significant messages. So this one looked at the outcomes if the patient was exposed to direct-acting antivirals before 13 weeks versus after 13 weeks. And as you can see, there are some significant outcomes that has been observed. They were not linked to treatment per se, but it's something that you should always keep in mind. And again, the justification, I think, to rush and treat a pregnant patient with such numbers, I'm not really inclined to do it. And this has been also highlighted in, again, there's a caveat here because this is a pharmacovigilance data, so it's basically reporting by the physicians. And it's always subject to selection bias, but the outcomes for a cohort of 335 patients who were exposed to direct-acting antivirals, 36 of them, we had the data. Abortions had happened in 23% of them. And those who had live births, again, 13% has congenital anomalies. Again, we should take all the data with caveat that it has been basically a pharmacovigilance database. But am I inclined to treat pregnant women? Personally, no. I don't think I'll be doing this soon. And the data here did not persuade me to do, actually it persuaded me that I'm doing the right approach. So the long-term reality of cure, what happened after cure, this is something that we already well established, and we'll just reaffirm it. What happened that basically a lot of patients have improvement in the fibrosis score, up from F4 or the ISHAX fibrosis score from 6 down to 4, 3, 2. And of course, the hepatitis activity index significantly also goes down. So again, this is just to reaffirm a message that we already well established. And this is the last abstract, the hepatitis C with major adverse events from cardiovascular point of view. And I think this is something that we don't focus on as we should, that hepatitis C somewhat shares the risk factors for other disorders, among them MASLD and MASH, and also the cardiovascular events. And this has proven that patients who have hepatitis C are more at risk of major cardiovascular events compared with the non-hepatitis C controlled group. And this has been, whether the hazard ratio is significant, whether it's unadjusted, adjusted, or even including the competing risks. The competing risks mainly are liver transplants and other major outcomes in hepatitis C. So regardless, it is still significant that patients would have more risk for major cardiovascular events. And I think I'm done with my presentation. This is the last slide. Thank you.